Good evening. Good evening. Okay. Good evening and welcome. My name is Yoel Khan, and I'm the senior rabbi here at Congregation Beth. It's my pleasure to welcome all of you here tonight for this important program. Thank you so much for making the effort to be here, and a special thanks to all of our participants who flew from East Coast, some came from more locally here, but everyone to be here tonight. I wanted to bring this program, this content to Congregation Beth and our East Bay Jewish community for many years, ever since I learned about the impact of the BRCA Genes mutations on members of our congregation and our community. I'd like to express my deepest thanks to my extraordinary volunteer partners in bringing this program here this evening, our adult education chair, Ethan Endelman, and his committee, and special thanks to Donna Friedman-Mayer, who's been our lead organizer over these many, many months. I want to say our thanks to our partners from the Vassar Center for BRCA at the University of Pennsylvania, Dr. Susan Domchek and Beth for their enthusiastic and supportive partnership with us, thereby enabling us to have this event happen. I also want to appreciate you guys for schlepping here from the East Coast to bring your insight, your expertise, and your wisdom to share with all of us. I want to extend my thanks to all of our panelists for sharing their personal and professional experiences. Yishabira Imotenu, Sarviv Kavracha Leah, the one who blessed our mothers, Sarah, Rebecca, Rachel, and Leah. Bless and care for all those whose circumstances we lift up tonight. We ask for wisdom and insight for researchers and healers, courage and strength to all who are living with these challenges. Together, may we help build a caring community, and may the wisdom that we gain by our participation and listening this evening help each of us on our journeys to living healthy, full, and meaningful lives. With that, it's a pleasure to welcome and turn over our evening to our moderator, Jill Werman Harris, who will take us to our presentation.
Hi, everyone. Rabbi Khan, thank you for your leadership. Both you and Donna Friedman-Mayer have been so enthusiastic and had so much energy for bringing this important conversation to Congregation Bethel and the wider East Bay community, so thank you both so much. I'd also like to recognize our event partners who are listed on the program for lending a hand in helping us bring people here this evening. As a journalist, I followed BRCA gene mutations for over 10 years, and I've met so many people who have struggled for answers. You know, heredity can be both a gift and a curse, as the past, sometimes uncomfortably, gives rise to the present. And it can be hard, really hard to do this. And the greatest health and healing come when we can gather together and share our experience, our strength, and our hope. And so on behalf of the Vassar Center for BRCA, we're delighted to be here, bringing knowledge and power to those impacted by hereditary cancer. So tonight we're going to begin our discussion with our accomplished panelists, and then we'll open up to questions from the audience. There's an index card in your program, and if you have a question for the panelists, and I hope you do, please write clearly on the card and hand it to the volunteers who will be coming by to collect them shortly. Following the Q&A, please stay for a bite to eat and meet the panelists and the lovely community of people who are here this evening. So tonight we'll be discussing the latest news and information surrounding BRCA1 and BRCA2 gene mutations, which greatly increase the risk of breast, ovarian, pancreatic, and prostate cancers, as well as melanoma. Now, these mutations are seen across all populations, both in men and women, and they're disproportionately seen in Jewish people of Ashkenazi ancestry. So this is the conversation that everybody with a history of these cancers needs to be having, and certainly every Jewish family needs to be having. So there's a lot to be learned tonight, and I'm delighted to introduce our distinguished panelists. First is Dr. Susan Domchek, who is the Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania. And Dr. Domchek is also the Executive Director of the Vassar Center for BRCA, which is the first comprehensive center for the research, treatment, and prevention of BRCA-related cancers. And for those of you getting their first introduction to Vassar this evening, it's an amazing organization, and it really has its finger on the pulse of both scientific and clinical research in this space. Critically, the center is breaking down academic silos by not only funding researchers within the University of Pennsylvania where it's housed, but around the globe in order to give families better choices and Dr. Allison Kurian is a leading medical oncologist with expertise in the area of clinical cancer genetics and epidemiology. She focuses on women at high risk for developing breast cancer and novel techniques for early detection and risk reduction. Dr. Kurian is an Associate Professor of Medicine and Health Research and Policy and the Director of the Women's Clinical Cancer Genetics Program at Stanford University School of Medicine. Dr. Samantha Langer is the Director of Breast Surgery at Kaiser Permanente at San Francisco Medical Center, where she has developed and implemented a highly regarded multidisciplinary hereditary risk and oncology clinic. I'm especially appreciative to have two very personal patient perspectives here with us tonight. Jen Brand is a project associate in development at UC Berkeley and a member of Congregation Beth. She is a BRCA mutation carrier and cancer survivor who has undergone treatment including bilateral mastectomy and hysterectomy. And Allison Caldas is an architect and also a member of Congregation Beth. She is a BRCA mutation carrier who has opted for both prophylactic double mastectomy and salpingo oophorectomy. Thank you all so much for being here. So I'd like to start tonight by building a foundation about the BRCA1 and BRCA2 genes. Dr. Domchek, everyone has BRCA genes. Can you tell us what these roles play, what a mutation is, and how these genes, which have been passed down through generations, increase the risk for cancer?
Sure. So just to get started, BRCA1 and BRCA2, which by the way just stand for breast cancer 1 and breast cancer 2. This is how we come up with gene names. That'll be easier. Okay. These are genes. Yep.
Very close enough.
These are genes that everyone has.
The other one was better.
It just might look weird, but that's all right. So everyone has BRCA1 and BRCA2 genes, and these genes actually help repair DNA damage, and a specific type of DNA damage where there's a double-stranded break, where there's a break in both copies. And so you need BRCA1 and 2 to keep your cells healthy. And what we're really talking about when we're talking about risk of cancer is if you inherit a bad copy of either BRCA1 or BRCA2. And we call those mutations or pathogenic variants. We have all sorts of names for them. But what it means is just that you have a copy of BRCA1 or 2 that doesn't work, and it doesn't make a functional protein. Now, you would think that we'd know exactly how inheriting one bad copy leads to cancer, but it turns out we don't exactly know how one step leads to another. We know that in most cases, not all, but most cases, at some point along the way, a cell loses the second copy of BRCA1 or 2, and the cancer develops. But we don't actually really understand that process very well, and there's a lot of ongoing work to try to understand it better so that we can work on preventing cancers. But having a mutation in these genes, as you heard, massively increases the risk of breast, ovarian, and other cancers.
Dr. Kurian, how prevalent are mutations in different populations, and how do the different risks compare to the risks in the general population for these cancers?
Yeah, it's a very good question, because sometimes I think there may be a perception that these gene mutations are found only in people of Ashkenazi Jewish descent, and that certainly isn't true. We see BRCA1 and 2 gene mutations in people of all races and ethnicities. And it's been estimated that in people who are not of Ashkenazi Jewish descent, that the carrier prevalence, the rate of having these mutations, may be somewhere in range of 1 in 400 or so. That's sort of a rough estimate of what we see. And then when we think about what the risks are when people are born with a mutation in BRCA1 or BRCA2, there are studies that show a range of different risk estimates, but I think it's fair to say that in general, for BRCA1, we think about a lifetime risk estimate somewhere in the range of a 65% chance of developing breast cancer. For BRCA2, about a 45% chance. And we would compare those to people in the general population, American women at average risk, whose chance is about 12%. So 1 in 8 for the average woman versus as much as 2 out of 3 chances for a woman with a BRCA1 mutation. We also see high risks of ovarian cancer with these gene mutations.
So BRCA1 and BRCA2 are not the same, and sometimes people think they are.
Indeed, no, 2 different genes, one of them on chromosome 17, one of them on chromosome 13, discovered close together in time and given similar names because of the pattern of cancer seen in the families, but not exactly the same. Different levels of cancer risk and different spectrums of cancers associated with mutations.
And I think also these are lifetime risks, correct? Can you talk a little bit about residual risk and the concept that people can outlive their risk, which is sort of fascinating?
You're already asking me hard ones early in the evening, but it's good. It gets us all started. Very good. So I think one key point here is that when we talk about risks, these are averages. And so I know all of us who work clinically in this space have been puzzled by families where, maybe one woman with a BRCA1 mutation develops cancer at 30, and yet her mother is in her 70s and nothing ever happened. And I give that as an example of the fact that, just like Dr. Domchek said, we don't always know why cancer happens. And these are estimates for any given person that in reality may vary quite a bit. So the estimate over the course of a lifetime, and here again studies have looked somewhere to age 70 or 80, we know that often people live a lot longer than 80 now, which is great, but in that range is about a 65% or so lifetime risk for BRCA1. Again, one could perhaps go up or down a little bit. But again, the question often arises, well, what if a woman is 60 and she has a BRCA1 mutation discovered, but she's never developed breast cancer? Should we believe that in the years ahead of her, she has this incredibly high risk? And the answer to that is no. We think that that much risk is not ahead of her, and that in fact she's probably outlived some of it. What does that mean? It really just means that when you watch people, and a lot of the time we do this through epidemiologic studies, that's one of the things I do, which basically is just about counting people and watching what happens to them. If you do that, you see that most people who get to 60 don't have such a high future risk of developing breast cancer with BRCA1. And so for whatever reason, it's sort of as though we've learned something about that person over her 60 years. And what we've learned is that for whatever reason, the mutation seems to be acting differently in her than maybe in someone else. That could be due to other genes. That could be due to other factors in her lifestyle or other things. And we're not always sure.
Interesting. And following up, Dr. Domchek, on what Dr. Kurian shared about BRCA-related cancer risk, a lot of people do think that if you're not Ashkenazi, of Jewish Ashkenazi ancestry, you don't have to worry. Can you tell us, though, why they're more prevalent in these communities and other populations?
It's such a great question and an important one. So in the Ashkenazi Jewish community, 1 in 40 individuals has a BRCA1 or 2 mutation. 1 in 40. So when you think about that, that's a very, very high number, 2.5%. And that's without asking a single question about a family history or anything like that. And there are the mutations that occur in the Ashkenazi population are usually, 90% of the time, 3 specific mutations. And the way to think about this is if BRCA1 and BRCA2 are very, very big books, like War and Peace. If you're of Ashkenazi Jewish ancestry, we know the 3 words that are misspelled in the book, okay? And so we actually can only just go and look at those 3 words. Now, it doesn't mean that you can't have a mutation in another spot. It's just most of the time it's in that spot. And why is that? Well, these are called founder mutations. And by the way, there are founder mutations in other populations. A famous one is Iceland, which we can get to in a minute. But founder mutations really mean that in a population, there is, if you will, a specific population that either by geography or religion or for other reasons is somewhat isolated. And there are also what we call bottlenecks. So if you will, you're going along as a population and all of a sudden there's a significant shrinkage in the population, okay? But that mutation makes it through, and so it becomes more concentrated. And I think everyone here can imagine in Jewish history how those sorts of bottlenecks occur. And so that's the reason that there's both founder mutations and then there's an increased prevalence. In Iceland, it's an island, and so there's one specific mutation, BRCA2 999del5, that is mostly the only mutation that's seen in Iceland. So there are other examples of founder mutations. And then one other point to follow up on is that, and Dr. Kurian mentioned, BRCA1 and 2 are related but distinct cancer susceptibility syndromes. So for instance, BRCA2 mutations have a much higher risk of male breast cancer, of pancreatic cancer, and of high-grade prostate cancer. So they're different, and the types of breast cancer, I think we'll get to this later, are different between the two. So we don't really lump them together. When we're counseling patients, we really do talk about them differently.
Yeah, that's interesting because I was going to ask you that a lot of people refer to BRCA mutations as the breast cancer gene or also the Angelina Jolie gene. But for the breast cancer gene, you've said they're not genes, they're mutations, they're mistakes of genes. Can you tell us why referring to a deleterious mutation is kind of misleading?
Oh, well, first of all, so I am a big Terry Gross fan. Does anyone want to listen to NPR? Okay, all right. So I'm going to work one day, I'm in my car, and Terry Gross is on the radio, and she says, she's interviewing someone, and she says something about the breast cancer gene. And I was really literally yelling at the radio, no, Terry, no. Because there's lots of genes. We're talking about BRCA1 or 2 now, but there's actually other genes that also can increase your risk of breast cancer. So and they have a very different pattern to them. It looks very different. So we like to be precise and talk about exactly, and so in this case, BRCA1 and 2 mutations, which increase your risk of certain cancers. And again, other gene mutations increase your risk for other cancers. So, and by the way, this is a minor point, but BRCA is the name of a test that was marketed by a company, and BRCA1 and 2 are the names of the genes, which is why you hear us repetitively saying BRCA1 and 2 instead of BRCA, which you might be more familiar with.
Mm-hmm. And also referring to it as a breast cancer gene really obscures the fact that men...
Very, very good point. Thank you for bringing that up. So BRCA1 and 2 don't just affect women. They absolutely have consequences for men. And to put even a finer point on, for BRCA2, the lifetime risk of prostate cancer is estimated about 25%. But this is the kind of prostate cancer that men die of, not die with. It's high grade, it's aggressive, it's more likely to metastasize. So it's really different, and it's really, really important. Men need to know their status too.
Dr. Langer, we'll get into more details later about surgery, but can you address how risk changes after prophylactic surgery?
Yeah, so we expect that we'll achieve a 95% risk reduction when we do a prophylactic surgery, and that's regardless of what type of mastectomy, because there are different types that we do ranging from total to nipple sparing. But in general, 95%.
Is the microphone on?
It is, I just need to move it right into your face.
95%.
That's better.
Okay, so let's move on to family history, which is obviously very relevant when it comes to hereditary cancer. Can you tell us, Dr. Domchek, how they're actually passed down to families, these genes?
Yes, so if you, remember you have 2 copies of each gene, and when you have a child, you give 1 copy, and your spouse gives the other copy. And therefore, every time you have a child, if you have a gene mutation, your child has a 50-50 chance of also inheriting that mutation. And it's a coin flip each time. It's 50-50 each time. And that does mean that sometimes we have five children and they're all negative, or 5 and they're all positive, because each time it's a separate coin flip. It's just on average, it's going to be half the kids.
Mm-hmm. Dr. Kurian, 2 questions. Who should get tested? And what happens if, small question.
She's laughing because I'm getting all the hard ones.
And what happens if an individual knows very little about their either ancestry or their medical history of cancer?
I'm going to do my best with these. So it is a particularly interesting moment sort of this month right now, because there has just been sort of a bit of controversy over testing guidelines. So for years in the world that we've lived in the last 2 decades, we've had quite strict guidelines that say you really shouldn't get tested unless you have not just, for example, a breast cancer diagnosis, but a strong family history of breast and or ovarian cancer that would make us worry that you might be one of those those people who has a BRCA mutation. In the last month, there was actually a statement released by the American Society of Breast Surgeons that said that, in fact, genetic testing should be made available to all breast cancer patients. So we are all in the midst of digesting that, and I think that's about as much as I'll say for now on that topic. But the rules in terms of who should get tested are moving very quickly. What I will say that I think is pretty clear is that because people of Ashkenazi descent have this high probability and range of 1 in 40 of having one of these genetic mutations, even without any sort of family history or asking any questions that would let us understand about more risk factors for them, we think about 1 in 40, we do think it's reasonable for people of Ashkenazi descent, if they wish to be tested, to pursue that testing.
I just want to follow up on one point, because as Dr. Kurian said, this is a hot time right now and in fact, I think we'll both be at, there's a group called the National Comprehensive Cancer Network, and we'll be there in April. I just joined, so I get that. One of the issues is that there's all these other genes. So it turns out that our guidelines are actually pretty good at finding about estimating who has BRCA1 and 2 mutations. They actually work quite well. The controversy is whether or not they pick up other genes, but on the other hand, some of these genes may not matter as much. So I think that this is why the epidemiology that Dr. Kurian does, and sort of, it's really been an important time. But in the Ashkenazi community, it's definitely, we have an incredibly low threshold. We will be talking later about potentially no threshold to do genetic testing.
Right, and we'll get into talking about those multi-gene panels in a little bit.
Yeah.
Let's talk further about testing for those people who want to find out. How do people, Dr. Kurian, find a genetic counselor?
She seriously is getting all the hard questions, and she traveled almost as far as I did today, because she came from Palo Alto.
I'm going to let up in a little bit. I'll move on.
It was my mistake. I was unduly optimistic about the amount of time it would take me to get here from Stanford. So my fault. Very happy to see everybody. So how do we find a genetic counselor? Again, these are topics that there's sort of a simple answer and a longer answer. But to be more simple about it, genetic counselors are fantastic professionals who are trained in specifically these issues of thinking about the likelihood that a person carries a genetic mutation, and to try and figure that out, they ask questions about people's ancestry. So again, things like so people of Ashkenazi descent. They would also ask about family and personal cancer history and come up with an estimate that a patient might have a mutation in BRCA1 or BRCA2 or any other genes that might be important to test for as well. So it would be a comprehensive assessment. They would then explain what the testing process is, what it does and does not reveal, and that can really help patients in making decisions. And then if patients do choose to get tested, typically a genetic counselor, often with a physician, often sometimes without, would then proceed to order a genetic test, which sometimes is a blood test, sometimes saliva.
What about the different tests that are available? Can you just quickly go over the founder mutation,
Sure.
the full gene sequencing, and the multi-gene panel testing, so people can
Absolutely.
figure out that there is not just one test?
Absolutely.
Yeah.
So again, when we're talking about these relatively specific mutations for the Ashkenazi Jewish population, just like Dr. Domchek said, we're looking at 3 specific sites. In a way, it's a pretty easy test. You're just going to those 3 misspelled words, and I really like the War and Peace analogy. But so you're just going there. It's sort of quick, get in, get out, don't look at a lot of other things. And the answer is pretty straightforward. Do you have one or don't you? And so that's a really simple test, and that can be a good one to do if somebody really doesn't have other risk factors except for the fact of their Ashkenazi heritage, and that's the main reason for pursuing testing. I think that's very reasonable. Sometimes, though, we are thinking about testing people for reasons beyond their Ashkenazi heritage. In fact, most of the time in the clinic we are. We might be testing them because they have a personal history of breast, ovarian, or another cancer, or because of their family history. And then we might need to go beyond just those 3 sites and those particular genes of BRCA1 and BRCA2. The first thing we would typically do would be to do full sequencing, to read the whole book, the whole War and Peace, look at every word, and see if there's a misspelling anywhere else, not just those 3 hotspots. And then, like you heard from Dr. Domchek, really over the past 5 years, there's been a surge in our ability to look at other genes. Had to do with lots of factors, but one of them being that sequencing got a lot faster and a lot cheaper. So you actually pay the same to test 2 genes versus about 100 genes in most cases these days. But so there is that possibility of testing more. And it really becomes a question of what do we suspect in a particular family. So again, if there's breast cancer of early onset, like you were hearing, there are several genes that might implicate. And so we might want to go broader than just BRCA1 and 2. Maybe there are other cancers in the family that would make us think of other genetic syndromes, and those can help us tailor our testing to what we see.
You know, as BRCA has become more and more familiar to people, people are getting tested at younger and younger ages. And I think there's some confusion. Can you just clear up, before I let you go, can you just clear up the difference between prenatal testing for common Jewish diseases like Tay-Sachs versus BRCA, because I think there might be a misconception that's included in that.
Sure, and here's where I start to get a bit out of my comfort zone, because I'm just an oncologist, but I actually looked this one up. So at any rate, there are common panels of prenatal tests for people of Jewish descent, and typically those are looking for autosomal recessive disorders, so one where you really need to get a harmful copy from each parent, one of each. And typically those are things like Tay-Sachs. There are a list of about 10 to 14 that different programs and labs will test. And they are often metabolic disorders, Tay-Sachs, things like that. And so those are sort of typically on a standard prenatal testing panel. Looking around at both recommendations and a number of centers in this area, we typically don't see BRCA mutations on that panel. Why would that be? Typically these are adult onset disorders, and so that's why usually that would be something that would be reserved for when a person is grown up and can make his or her own decisions.
Right.
Typically we don't see any reason to test in childhood because there isn't cancer risk.
And that's actually leads to my next question for Dr. Domchek. A big challenge is figuring out at what age is best to undergo testing.
It's a great point. So in general, when we said we're going to talk about management, I'm sure in a little bit, but for women, we generally start screening at age 25 in the United States, and we start a breast MRI at that time. So we usually talk about testing at 25 because that's when we're going to do anything about that. Any adult, though, can come in for a discussion. So we certainly have had young women and men come in at 18 or 19 and come in for discussion. Sometimes they talk to us and they say, okay, that's great, but since you're not going to do anything, I'm not very interested right now. Other times, people have a very strong reason for wishing to proceed with testing. For the men, it gets a little trickier. Our recommendations for men are much more expert, which, by the way, when we say it's based on expert opinion, it means we made it up with all best intentions. And for men, we don't really do anything till 35 or 40, but, which we'll talk about later, it can have implications for reproduction. So sometimes people want to use this information for family planning purposes, and I think we'll get into that later.
Yeah, let's move into results for a moment. Dr. Domchek, when someone gets a result, some people get that they're positive for a deleterious mutation. Others receive something called an uninformed negative, or a variant of unknown significance known as VUSs. Can you explain these?
Yeah, so it's very important to differentiate these. So if you have a family member who has tested positive for a gene mutation, and then you're negative, that actually is quite informative. That we call that a true negative for a known mutation in the family, and it's very helpful. But if you have a family that has tons and tons of breast cancer, you yourself don't have breast cancer, you get tested and you're negative, that's considered an uninformative negative. That didn't tell us anything. It didn't tell us why there's cancer in the family. So we always have to be very careful. Sometimes we have people come in and they're thrilled that they tested negative, and we're like, well, you're right, you're negative, but it still didn't explain why there's cancer in your family. So we always have to take that with a bit of a grain of salt. The third possible result is this variant of unknown significance. Now, I will tell you that if you're doing, and again, not to go back to that analogy, but if you're doing the 3 words in War and Peace, we really don't see these VUSs, so that's sort of a nice thing. But if you do the whole book, oftentimes you can have a word that's spelled differently, but it might not matter. So, you know, in theater, depending on whether you live in London or New York, are spelled differently. It doesn't affect what that word means, and it doesn't have any implication. But when we do, these genes are huge, and so when we do this testing, we can come up with results that look different, but we don't know whether it impacts the function of the protein or not. If it impacts the function of the protein, it's a problem, but if it doesn't, it doesn't matter. But it can be very hard to hear that you have a finding that we're not sure what to do with. In general, we don't act on it, but it's there. And so it can be a challenge for patients and providers alike. And there's actually some evidence that providers don't always do the right thing with this information. So it is a little bit of a problem. Not a little bit, it's a big problem.
Jen and Allison, you both have stories that epitomize what BRCA mutation carriers have to face. Jen, your mother and her brother, your uncle, were both diagnosed with breast cancer, and ultimately you were as well. And at the time of your diagnosis, you hadn't yet been tested for a BRCA mutation. Can you tell us about your experience and how that information kind of unfolded and impacted your life?
Sure. Can everyone hear me?
Yes.
So, as Jill said, I was 35, and I was given the opportunity at a younger age to get the test, and at the time decided, based on family history and knowing that my own mom had the mutation, I opted not to be tested earlier on in my adult life because of my fears of issues with insurance and just my choice to be ignorant at the time. And then when my youngest child was 9 months, I had my baseline mammogram, and it was, there was something suspicious, but they weren't sure because I was nursing at the time. And fast forward 6 months, I went back in for a breast MRI, and it turned out that that suspicious area was a tumor, was a malignant tumor. And at that point, it was in my lymph nodes, and I had a bilateral mastectomy, and before I had any treatment, I then went in and had all of the genetic testing done, because the doctors all said, you really need to be as informed as possible. That will determine how aggressively we treat you. And at that point, I discovered that I was positive for the mutation, if that's a correct term. But I had the mutation, BRCA2, and at that point we went full tilt and double mastectomy. I did the 6 months of chemo, and after that oophorectomy and hysterectomy, and then I'm now in my 9th of 10 years of hormone treatment.
And then actually, Jen's story, both Dr. Kurian and Dr. Domchek, illustrates that BRCA status does change treatment, doesn't it? Or can?
Yes, this is rapidly evolving as well. In the earlier stage setting, it clearly can impact choices of surgery, which I am sure we'll hear about. From the standpoint of, and it impacts the fact that a new oophorectomy was performed to decrease the risk of ovarian cancer, which actually has secondary impacts on which hormonal therapy we use. So all of that is sort of related. It is rapidly evolving what we should do differently in terms of what we call adjuvant therapy. So when someone's diagnosed with a local cancer, we give adjuvant chemotherapy, adjuvant hormonal therapy. And so there is always a discussion about platinum use as a specific chemotherapy agent, and BRCA1 and 2 related tumors are more sensitive to platinums. That's not usually used in estrogen receptor positive cancers. And we also have ongoing studies looking at drugs called PARP inhibitors. In the metastatic setting, in patients who have cancer that's spread outside their breast, PARP inhibitors are approved for BRCA1 and 2 related metastatic breast cancer and also ovarian cancer, and I think soon will be approved for BRCA1 and 2 related pancreatic cancer. And so these are really active drugs, but there's a very large ongoing study of 1,800 women throughout the world. Half, after they get all their therapy, are getting a PARP inhibitor in addition, and half are getting a sugar pill, because we need to know whether or not the risks of the medication outweigh the benefits or vice versa before we do that routinely. So that was a long answer, but yes, it's important knowledge.
And you mentioned pancreatic cancer, which leads us to Allison's story. Allison, you have a history of pancreatic cancer through your father, who was a physician, as you told me, and your grandfather. And every mutation carrier with whom I've spoken remembers the moment that they were told, that they were informed. Can you tell me, or all of us rather, what that moment was like for you, how you processed it, and how you navigated through the medical decision-making that BRCA carriers are faced with once learning about their status?
So my father, in late 2006, he was diagnosed with pancreatic cancer, and he was a physician, he was an OBGYN, and at the time he was kind of traveling around the country trying to find just doctors to help with any of the treatment for pancreatic, and it was, the end of 2006, he actually ended up seeing a doctor, Dr. Fine, in New York at Columbia. And he kind of put it together. He said, "Oh, you're Ashkenazi," and my dad's father, my grandfather, had passed away from pancreatic cancer when he was in his 70s, like in the early 1980s. And so he pieced it all together and said that he'd been tested for the BRCA gene, the BRCA gene, and so at that time, during while he was being treated, he had a test, found out he had BRCA2. And immediately, when he saw my brother and I, not long after that, he immediately told us, kind of explained everything, and said, we need to go get tested. At the time, I was almost 27. And and I was living in LA at the time. I was in grad school, and so my dad, I think he even found out, like, the place nearby that I could, as far like just my choices as far as where to get tested. So I went to Cedars-Sinai in LA. And got in touch with the genetic counselors there, and just got the test as pretty much as fast as I could, just taking his advice, especially as a medical professional himself. And so I went and got the test, and I don't remember now, but it sort of seemed like a long time until I got the results. I don't know if it's different now, but
It's better now.
it was a blood test at the time, and I sort of remember waiting around for a while, and got a phone call to come in to get the results, and found out that I have the BRCA2 mutation. And I was just at the appointment by myself, but they kind of gave me a minute to see if I wanted to make any phone calls or anything, and I just talked to them and found out their initial information that they gave, and I called my dad right after the test and told him, and he just kind of reassured me right after that just to always do what advice I got from the doctors, and just to always be proactive now that we do this information. And the fact that he found out he had the cancer, and then found out he had the gene afterward, and so he just said, the fact that you have this gene mutation, you can move forward with this knowledge.
Thank you both for sharing your stories. It's interesting to think about parents passing on this legacy to their children. It can often carry a tremendous amount of guilt on behalf of the parent. And Dr. Domchek, one of the challenges we've discussed is whether to tell children that a mutation runs in the family. Can we talk about that for a minute?
Yes, I think one thing that's been interesting for me in my practice, and this is a little bit anecdotal, and I'd love to hear others. Young individuals that are growing up these days have heard all about genetics. They've learned all about genetics, and they kind of already almost understand that good and bad things are inherited. And so when we test 25-year-olds now, I've never seen a single case where the 25-year-old has turned to the parent and blamed them for it, because they're just like, good things and bad things are inherited, and that's what it is. Parents don't feel that way, obviously they feel terribly. But we really tried to say that we all pass along good and bad things to our children, and